specialties that you can see here. So medicine, surgery, elderly care, pediatrics, psych, obs and gynae, and GP. So today I'm doing the medicine section, and next week it will be the elderly care. So in addition, we'll also have dedicated sessions on calculation skills and also emergency drug prescribing. So today I'll be covering this bit here for the medicine section, but not the calculation skills because we'll have separate sections for that. So today we'll go through questions such as prescribing writing, prescription review, and teach you guys strategies to approach them effectively. We'll also cover key teaching points on common conditions. And if you have any questions at any point, just put them in the Slido. So this website at which you scan the QR code in. And this is monitored, like we said, and we'll be looking at those questions. Fine, so let's start then. So that's the first question of the day. So this is a 64-year-old man coming in with severe headache and visual blurring. So he has a history of poorly controlled hypertension and asthma. So looking at his observations, his BP is obviously high, heart rate is 88, rest rate is 18, saturating at 97% on air. Fine. His past medical history includes hypertension, asthma, CKD stage 1 gout. So his medications are listed here. So hypertension, he's on ramipril, amlodipine, allopurinol for the gout, salbutamol, and the other inhaler for the asthma, and the statin, basically for primary prevention. So he has no known allergies. So on examination, you see that he has bilateral papilloedema. There's no chest pain or neurological deficit. So what I want you guys to do is to write a prescription for a drug that is most appropriate to treat this condition. So I believe, Charlotte, is it that they will put it in the chat? Is that right?
I think plan going forward is to use Slido, but I think
Okay, so which one would you like to choose?
So it's up to you. If you want to see people's answers, that's fine. If people want to put them in chat, but equally if people want to do this as a more of a like old school paper and pen exercise, that's fine. It's up to you as teacher. But people can put them in the chat, that's fine.
Yeah, then it would be easier to put it in the chat because I'll be able to see them.
Yeah, go for that then, guys.
That's fine. So put them in the chat. I'll give you 30 seconds or so. And then I'll show you guys basically how I will approach this question. Fine, I can't see any answers in the chat. Let's just go through it together. There are plenty of opportunities afterwards. We'll have many questions again. So this is the answer I was looking for. So to basically come up with this answer, this is how I would have approached it. So basically, when you have this section, when you're preparing for this section, so you have to find the right diagnosis first. So remember that this is the PSA, so it is not testing your diagnostic skills. So the diagnosis will be straightforward. So in this case, the diagnosis would have been hypertensive emergency because this patient is obviously hypertensive and has got symptoms associated with the hypertension. So it's hypertensive emergency. Secondly, you need to read the question well, what they are asking for and which drug they are asking for. For example, sometimes they will be more specific in terms of whether they want an oral drug, an IV, an IM drug, or whether they would like a drug that makes the patient so not drowsy. So just read the question really well because the drug that you're going to prescribe, basically I've written it here. So you will get 10 marks for this section, 5 for the drug choice, 5 for the dosage, route, and frequency. If you get the drug wrong, so basically also most of the time the dosage, route, and frequency would be wrong. Maybe the route would still be IV or oral, but the other bits might be wrong as well. So the first step is to get that drug right. So for you to get that drug right, what you can do is just, so from memory, if you know the condition is hypertensive emergency, you know in your mind, well, the drug that I would use is IV labetalol, fine. So you know what you're using. If you don't know, then there are treatment summaries to help you. So on the BNF, basically there are treatment summaries where you can search for specific conditions. So for this one, the treatment summary would just be you type hypertension or antihypertensive drugs, and it will come up with basically a treatment summary for it, where there will be a list of antihypertensive drugs for you to choose from. And then once you get that drug, you need to make sure that basically you can use it. That is, they are not allergic to it. There's no other drug interactions. The past medical history. So basically, this patient has asthma, so you can't use labetalol for this one. So you need to choose other medications for it. So whether the bloods are fine, the observations are fine as well for you to use that medication. So once you know which drug you're using, then you use the BNF to correctly prescribe that drug. And when you are prescribing it, you need to choose the
Put
right
it in a cup
dose.
and water in the basin.
Sorry, so when you're prescribing it, you need to make sure that you get the right dose. So basically, if someone has a renal impairment, a hepatic impairment, or they are elderly, so on the BNF, they will give you a reduced dose for those patients. So you will need to adjust it based on those doses. So once you get all those steps right, so that's when basically you're kind of guaranteed you are getting all the points. So if we go back here to that question, so the first principle is you get a diagnosis right. So you know it is hypertensive emergency, fine. So you know from memory, so I knew that it was IV labetalol because I knew that from medical school per se. But basically, this is contraindicated in asthma. So what else can I use? So what I did was going to a treatment summary. I know that there's a treatment summary for antihypertensive drugs. I typed that. So I look into it. There are those two drugs here that are used in so basically hypertensive emergency. So I go into that first drug, hydrolazine, and then I look whether I can use this drug. So basically, there's no contraindication in terms of asthma or CKD or gout. So basically, there's none. So I can prescribe it. So I prescribe it as per the BNF. So that's what they recommended me to do. So that's the answer here. So going along, if you can just follow this format, this will help you a lot. So next question, or not next question, but basically, uh, this is a list of acute medical conditions which you can be asked about during the PSA. So I've made up that list, taking into consideration a lot of like commonly occurring medical conditions in hospital as well as in the PSA. So in the PSA exams, sometimes you will be asked about pain management for people coming in with ACS. So the first line would be like you prescribe sublingual GTN for them, which would be one tablet once only. And for that, you need to remember that it may be repeated at 5 minute intervals and a maximum of 3 tablets can be used because sometimes in the questions they will tell you that they've used those 3 tablets. So what else can you prescribe? So that's when the other option would be IV morphine, which you can prescribe for the pain. So the usual dose, it would depend, but usually it's 5 to 10 milligrams, so single dose for those patients, and it is IV morphine, not oral, for you to get the full, I guess, marks. And the treatment summary for ACS would be acute coronary syndrome, which you can search on the BNF. So next condition is decompensated heart failure, which basically the question would tell you that this patient came in with shortness of breath, chest X-ray showed bilateral, so pulmonary edema, and your option would just be to offload them, which you would use IV furosemide. And usually the dose will be 20 to 50 milligrams, single dose you would prescribe. So hypertensive emergency we've gone through. So those are the treatment summary that you can use. So anaphylaxis is a good one. Basically, for anaphylaxis, you will be prescribing adrenaline, so intramuscular adrenaline for that patient. And the dose would be depending whether it is adult or peds, so whether it is children or adults, because for children it is prescribed, I think, per weight, but for adults, standard is 500 micrograms. So the main thing to remember is adrenaline is also prescribed in cardiac arrest, but for anaphylaxis, the concentration is 1 in 1,000, while in cardiac arrest is 1 into 10,000, the concentration. So that's where they can trick you, where they can give you the same dose, but the concentration is different here. So you need to choose the 1 in 1,000 one for anaphylaxis. And remember, it is IM for anaphylaxis, while for cardiac arrest, it will be IV adrenaline for those patients. Anyways, the next condition is status epilepticus. Basically, you would give them, if they are in hospital, obviously they have an IV access, then you would give IV lorazepam for them. If not, if it is in community, then you would give PR diazepam. It's just for you to remember the name of those drugs so that when you have those conditions, you know what you're looking for, and it's easy for you to just look up on the BNF. Next one is hypoglycemia. Basically, if they're conscious, able to swallow, then they would be given like an oral glucose formulation. If not, you would either give IM glucagon or IV glucose 10%. So some of the questions they would ask you about the glucose. So basically, which concentration would you use? So usually you use 10%, and if it's not available, you would use a 20% one. However, sometimes we put 50%, which we don't use at all because 50% is just too concentrated. So you will only choose between 10% and 20%. The last one, well, there are a lot of acute medical conditions, but this one is DVT or PE, which you would use oral apixaban or rivaroxaban. Basically, the length of the treatment depends on whether it is provoked or unprovoked. So I think for provoked, you need to give that drug for 3 months, while if it is unprovoked, it will be 6 months. Um, so now I've gone through those conditions. So basically, for them, I just want you to remember, basically, when you have those questions, just go on the BNF to look at the dose and frequency as well as the route. So just remember the name of those drugs, basically. So next question. Well, you've got 68-year-old female presenting to hospital with shortness of breath, past medical history of AF, hypertension, type 2 diabetes, and COPD. So on apixaban for AF, amlodipine for the hypertension, metformin for the diabetes, and then inhalers for her COPD. She's allergic to penicillin. Otherwise, when you look at her blood, so at the ABG, you see that basically she's acidotic, she's got a low PO2, a high PCO2. So in your mind, you're thinking type 2 respiratory failure. So her bicarb is basically on the lower end, so there's no metabolic compensation. So she's having an acute exacerbation of COPD with type 2 diabetes. No, sorry, with type 2 respiratory failure. So my question is, so write a prescription for this lady for one drug that is most appropriate to treat this condition. So she's already on, if you read the last line, she's already on salbutamol 2.5 milligram nebulizer 4 times daily and prednisolone. So what else can you add on to her treatment, knowing that it is an acute exacerbation of COPD? So can you just type in the chat what you would be prescribing? I'll give you 30 seconds again. So I can see a question here where you've been trying to find the hypertensive emergency drug section. That's fine. I can show you now. Let me just stop sharing this one. So keep typing the answer to that question. So I'll just show you for the hypertensive emergency one. So basically that's the BNF. I think it was so there's two that you can use. So there's antihypertensive drugs. So when you go down, those are the options that they give you. So hydralazine is given by mouth as an adjunct and for treatment of resistance, or sodium nitroprusside is given by IV infusion. So if you go on both, so you can see, so if you go on to this one, you can see the indication for them. So in hypertensive emergency, so then it gives you the dose as well, which one you would use. Or like for this one, sometimes when you can't see when you can't find the treatment summary, you can just type hypertensive emergency. What it would do is that it will give you all the drugs with the indication of having hypertensive emergency in them. So when you type this, you would find the drug hydralazine is there, sodium nitroprusside is there, labetalol is there. So I know that this patient was contraindicated to have labetalol, so I chose one of those two. Um, but yeah. So from my understanding, we will be using the desktop one, the desktop version of the BNF. I know that the mobile version one is a bit better as well. Um, but you will be using the desktop one. Yeah. So I've stopped sharing. Let me just share again. Sorry. Um, fine. So for this question, let's see. So yeah, I've got an answer here. Ipratropium 500 microgram nebulizer. So basically that's the right answer. And like I've said, we are treating this patient for acute exacerbation of COPD. So I just prepared this slide here, which will go through the acute respiratory conditions which can be asked about and the respective doses which you can prescribe. It's all in the BNF as well. It's just for you to just know. It's just all in one place, for example. So for acute asthma, so you will be giving basically in an acute episode. So salbutamol nebulizer, it will be 2.5 to 5 milligrams. You nebulize it and you give it usually every 15 to 30 minutes. So then in real life, you would assess the response. So basically it will either be peak flow or in terms of the symptoms as well, whether they are getting better. Also, if they have severe or life-threatening asthma, on top of that, you will be adding ipratropium nebs. So again, 500 micrograms nebulized 4 to 6 hourly PRN. Um, One thing is that when you compare the treatment for asthma and COPD, they're kind of the same with using salbutamol nebs and ipratropium. Only for asthma, if they have severe or life-threatening, that's when you give ipratropium. But for COPD, you always give it with the salbutamol nebs. The main difference will be in the prednisolone, where the dose is different. So the prednisolone for asthma is always higher, 40 milligrams. You give it orally for 5 days. But if they can't take orally, so the question will tell you whether they can or they can't take orally, then you give it IV, IV hydrocortisone, 100 milligrams every 6 hours until they are able to take orally. But for COPD, you give it 30 milligrams for 5 days. That's the main thing that it can trick you in terms of the dose for the prednisolone. So here I've just put in a tiny bit about some practical tips in real life. So on the ward, if someone has an exacerbation of asthma or COPD, so how you would approach it. Well, it's not really relevant to the PSA, but it's just for you to know that in real life, what you would do is you do an A2E, you look at their OBS, you do an ABG, you do bloods just to rule out any infective causes and rule out other things like you would do a D-dimer to rule out a PE if it is an acute, basically shortness of breath episode. You would do chest X-ray to look for any infective signs, basically whether they have pneumonia or not. You do a respiratory swab to see whether they have any kind of influenza or COVID positive, sputum culture if they're productive of sputum. Then you decide whether or not do they need the sepsis pathway or they actually that unwell. So based on their new score and on their observation, are you going to give that patient antibiotics? Are you going to install them of oxygen? Obviously, you have started them if you know they have a past medical history of asthma or COPD. You have already started them on the salbutamol nebulizers and ipratropium and all that, basically the initial treatment. But it just things here. that I've put in that will help you in real life later on as an F1. So, next question. So this question, I'll just put it in just to check your memory because I went through that before in the previous slide. So 23-year-old male admitted to hospital with flushing, pruritus, followed by throat tightness, wheezing, and dyspnea. Has a peanut allergy, obviously, and stated that his symptoms started after eating a biscuit at home. So past medical history of asthma, allergic to peanuts, penicillin as well. Basically, when you look at his observation, he's not that well. So his oxygen saturation dropped to 91%. And basically, his heart rate is high. So he's tachycardic, got low blood pressure, and his oxygen levels is low as well. And when you listen to his chest, he has got an audible wheeze. So what would you prescribe for this patient? Give you 30 seconds, put it in the chat. So you put the drug, the dose, the route, and the frequency. So I'm going through the chat. I can see one answer to the previous section was clarithromycin. It just to know that, so on the previous slide, there was no indication that it was an infective exacerbation of COPD. So the main thing is to prevent the patient from being acidotic, which he or she was already. So just to make them better from the respiratory side of things, and giving antibiotics now, not knowing that they have infection, wouldn't be an immediate, I guess, immediate thing to do. It would be to give the ipratropium alongside the salbutamol nebulizer that would help them. And there was nothing on that, I guess, vignette that would say that they have an infection at the moment. Um, Fine. So for this question, like we said, the answer is adrenaline 500 micrograms. So it will give you different options to choose from. So it will be the 1 in 1000 IM and give it just one dose, so once only. Um, the main reason why we give it, so um, in cardiac arrest, we give 1 in 10,000 versus this one in 1000. It's just because for this one, we're giving it IM. So we are not giving it directly into the bloodstream. So we need to give a more concentrated dose. So that's why it's 1 in 1000 because you're not giving it directly into the bloodstream. While in cardiac arrest, you're giving it directly. So you need a less concentrated one. So that's how I remember it, which one is which because you're giving this one IM, so it should be more concentrated for more of it to get into your blood afterwards. While for the other one, it doesn't need to because you're giving it directly into the blood. Fine. So let me just see. So I wanted to put a slide about insulin prescribing because that's a bit, I guess it comes up a lot as well in the PSA. Um, So in terms of insulin types, so you've got your rapid, short, intermediate, long-acting, and your biphasic insulin. So I tried to summarize all of them in that slide that we will be going through, um, because you will be prescribing those medications basically. So you need to know what you're prescribing and how you will be prescribing them for your patients and in the PSA, obviously. So your rapid acting insulin, when you will be prescribing it, insulin is always prescribed by brand name. But in the PSA, you can write the brand name as well as the name of the insulin. So Novarapid, Trurapid, and Fiasp, those are brand names, but the generic name is insulin aspart. So when you type insulin aspart, it will give you so all three options. You can choose which one you want to prescribe. Um, so rapid acting insulin, those are the ones that you would give it with meals. So before a patient have their meal, you give it before the meal, they have their meal. So that's the short acting insulin that's meant to basically regulate the insulin, the glucose level after their meal. So this one will be given subcutaneously. So the route will be SC. And just for you to remember, it peaks 2 hours after you've given the insulin. So in real life, say you are on a night shift, a patient has high glucose level and you decided to give them a so basically rapid acting insulin. And then after like 30 minutes or 1 hour, the nurse bleeps you, tells you that the blood glucose level is still high. So you need to know that it takes at least 2 hours to peak. So it's not a cause of worry because the insulin hasn't acted yet. So it's just some things for you to remember. And for the rapid acting insulin, you always need to hold it when a patient is on variable rate, fixed rate, or they are nil by mouth. Just because when they're on variable rate insulin or fixed rate, basically you're already using uh, you will be using a short-acting insulin that's running continuously. So you don't need to give further like short-acting insulin with meals. So that's why you hold it. And obviously someone is nil by mouth, so they're not eating, so you wouldn't be giving it because they're not taking their meals. The next insulin is the short-acting one. This is the one that you would use when a patient is on variable rate or fixed rate. So it's called human soluble insulin or Actrapid. So this is the one that you would use, you would prescribe in a PSA as well if you're asked to prescribe for a variable rate or a fixed rate. So just remember, if someone has DKA, you would prescribe a fixed rate and would be at zero point 0.1 unit per kilogram per hour. And the route for this one, it is IV, so we go through the vein. While for the other insulins that we will talk about, it is all subcut. So remember this when you prescribe. So then there's that category of intermediate insulin. Well, I didn't actually put a bit on it. It's just because it's not that well used as well. And there's little question that comes with it. But the name of the insulin that you can prescribe it is intermediate Humulin I, and it is given as a once or twice daily regimen. Next, we've got the long-acting insulin. So long-acting is mostly you will have Lantus, Levemir, Tresiba. So those are the brand names that I've mentioned. But the actual name would be insulin glargine, Ditamir, or Deglutec. Yeah, that's how it's pronounced, anyways. So for them, you can either prescribe them once daily or twice daily. It kind of depends because some of those insulin, they are ultra long acting. So like I believe Tresiba is the one that's very so ultra long acting. So you would be only prescribing it once daily. So just because its effect will be lasting more, like a lot more compared to the other long acting insulins. Um, but yeah, so just remember you would prescribe it once or twice daily, subcut again, and this is the insulin that you will continue when on variable rate, fixed rate, or even if they are nil by mouth, but you would decrease the dose. Um, Next is biphasic insulin. Biphasic just means it combines a rapid acting plus an intermediate or a long acting. So it would give you the same shape of that graph, but basically it also depends whether you're giving an intermediate or long acting with it. So you give it twice daily. So at the time the patient is having their meals, basically. Um, so just some tips for you guys. So insulin is prescribed by brand name. When you do prescribe it on the wall, the units is written in full, just to prevent some confusion when you just write U next to the number, so to the insulin that you're prescribing. So you write units in full. Again, if the patient is nil by mouth or anorexic, so they're not eating by themselves, so you have to reduce the dose of the long-acting, intermediate-acting insulin as well as the biphasic insulin, but you hold the short-acting because they're not eating, so you don't need to give the insulin before they are eating because they're not eating. So if they are hypoglycemic before a meal, you need to remember to correct the hypo first, then you give the insulin before the meal, and then you ensure the patient has the meal after. So it's not like they are hypo, so you don't need to basically correct the hypo, you just tell them to eat the meal. No, you need to correct it with like your oral, so either your oral hypoglycemic agents or like the IV glucose. It depends on how low the BM is. But you need to correct it first. Then you give the insulin, and then you ensure the patient has their meal. And when I say insulin, is the short-acting one, basically the rapid-acting one before their meal. If they are hyperglycemic, you always check ketones to check whether or not they're in decay or not. You don't know, so that's why you check the ketone. If the ketone is high, that's when you would do a VBG to check whether they're acidotic or not. So just to remember that. Next question. A 68-year-old woman has presented with symptoms of basically GORD, gastroesophageal reflux. So past medical history, ischemic stroke, hyperlipidemia, hypertension, type 2 diabetes. Patient is on clopidogrel, amlodipine, statin, metformin. The investigations included H. pylori negative. So which drug would you be prescribing for this patient that is most appropriate to treat this condition? Just put your answer in the chat. Let's see. I've seen the question about ipratropium not being on the COPD treatment summaries. I've had a look at as well. I can't see it there, but usually this is what we are taught about. So salbutamol, ipratropium, and then you keep the prednisolone with it. Let me try to see whether I can find whether there's anywhere else on the BNF which says. Um, and then if you were to use a long-acting, do you give short-acting or rapid-acting with it during the day? So yes, um, so there are different regimens of insulin that you give patients. So that one that you're talking about is the basal bolus regimen of insulin. So you have to give the patient long-acting insulin, and then the long-acting insulin will give you a background dose of insulin that every one of us, so you and me, our pancreas produces a basal insulin that's always there. So you need that basal insulin, that's background insulin. Those patients that don't have that background insulin, so we need to give them a long-acting insulin. And then the other ones, the acting or rapid-acting ones. So basically, you're using the rapid-acting or the short-acting ones. So the rapid-acting ones, you need to give them before a meal because in your body, pancreas produces insulin due to a rise in glucose. So when you eat, the pancreas reacts. There's a rise in glucose, produces insulin. So it kind of mimics that rise in insulin. So that's the regimen that you have to use. So you give your long acting in the morning, then during the day they have the rapid acting with the meals. The other regimen you can have is like with biphasic insulin. Because they are biphasic, they do have their rapid acting and the intermediate or long acting. So basically, you would just be giving that insulin twice a day. They don't need any rapid acting just because they already have the rapid acting in them. It combines both rapid acting and long acting. Um, so when there's a time range stated on BNF, will that be part of your answer? It depends. So if you mean time range in terms of the like you'll be prescribing it for 4 weeks, for 8 weeks of for the omeprazole, for example, Well, it depends what they want you to write. So on the BNF is for 4 to 8 weeks, but like in the format that basically they want you to answer is just the drug. So if you write omeprazole, it's the drug, and then the dose will be 20 milligrams, and then it will be the route will be oral frequency once daily. If they want to ask you the length of time, then you have to put it, but it kind of depends on how they phrase the question. So I can see a lot of omeprazole there, but the actual answer is lansoprazole or pantoprazole. The main reason being, um, well, um, fine. So you got the right diagnosis, which is good. Fine, we know that. The right drug, I would have gone for omeprazole as well, and then you have to look at the past medical history or drug history. So for this one, because this patient is on clopidogrel, yes. So if you look on the drug interaction things, with clopidogrel, it says that omeprazole or esomeprazole is predicted to decrease the efficacy of clopidogrel. So you can't give that one. So you're left with the option of lansoprazole or pantoprazole, which has no interaction with the medications. So that's the question that basically you have to look into the drug history. And it's not really obvious because I wouldn't have known either, like omeprazole would decrease the efficacy of things. Because even in hospital, like it would basically be the pharmacist tells us, well, this is what's happening. Do you want to change it? But for that exam, basically I would advise you if you just put in the interaction checker to make sure that what you're prescribing is the right one. I hope that makes sense. Um, well, some common chronic medical conditions. So we went through this one, dyspepsia, which covers cold, peptic ulcer. So there can be like dyspepsia can be caused by side effects of medications or malignancy as well. So like we said, usually the first line, if it is undiagnosed dyspepsia, you would go with a PPI for 4 weeks, and then you would test and treat if they have H. pylori or not. So treatment summaries will be dyspepsia or H. pylori. You can have a look at it, especially for the H. pylori because they recommend different kind of antibiotics for it. Next for hypertension, so basically the pitfall that you can go into is that basically for hypertension they want you to prescribe an ARB, so rather than an ACE inhibitor for African Caribbean origin people. And also, if you're starting a diuretic, you use a thiazide like diuretic like indapamide for hypertension. Next is like heart failure with reduced ejection fraction. Basically, for that one, because it's a chronic medical condition, the patient can just come in with some edema in the legs. You just have to use some loop diuretics for symptomatic management. So there's a difference between symptomatic management and management that can basically makes the prognosis better, which would be ACE inhibitors and beta blockers, while loop diuretics like furosemide just help with the symptoms of edema. The treatment summary will be chronic heart failure. So for AF, basically, you treat AF in two different ways. Either it is rate control or rhythm control. It depends on the question what they want you to prescribe. So if it is rate control, they would ask you whether, like, so then you have to choose, sorry, whether you want to prescribe beta blocker, calcium channel blocker. Sometimes digoxin as well can be used as rate control, but then they will ask you specifically to prescribe digoxin. Then you need to basically look at contraindications and all that. So rhythm control, you can use flecainide or amiodarone, and then other things with AF, you need to consider CHA2DS2-VASc score because they're at higher risk of getting a stroke with AF. Next, other conditions that you can come across is hypothyroidism, where you would prescribe levothyroxine sodium. So the main treatment goal for hypothyroidism is to maintain the TSH within the normal range. So if the symptoms persist while the TSH is in the normal range, you still have to give them increasing dose of levothyroxine, but ensuring that the TSH still stays in the same range, the normal range. There are other medical conditions. There are a lot like diabetes, stable angina, hyperthyroidism. We'll try to cover some of them during that session as we go through. So the last question for the prescribing is a 68-year-old man presents to GP with melena. So fine. So that's not prescribing, that's prescription review. Anyways, that's the next section. So a 68-year-old man presents to GP with melena. He started treatment for CAP 3 days ago. So past medical history, type 2 diabetes, hypertension, depression, so a lot of things going on. Drug history, they're listed on the right. So on examination, you see the OBS. So just the heart rate is a bit high, I believe. Yeah. And nothing else on the examination. So investigation wise, you look at the bloods, they look fine. Yeah, they look fine. Uh, yeah. Okay, ECG is normal as well. So for that question, they want you to select three of the prescriptions that are most likely to directly or indirectly contribute to melena. And secondly, select the one prescription that has been wrongly prescribed. So just put the answers in the chat, which one you think. So if it is moderate severity, you wouldn't lose, I don't think you would lose all your mark, to be honest, but it doesn't give you the full mark, like they don't give you the full mark for it. Would you always check every answer in the interaction checker? No, not really, because the time wouldn't let you. So that's why I said even if it is moderate, like it's not, so it's not a contraindication to you prescribing it. Um, but still, like you wouldn't get the full marks because of it. So which one you will use the interaction checker? That's a good one. It just because you know, like when I told you about the marks. So for this one, the prescription one, you get 10 marks per question. So it kind of depends, like if you get the drug right or not. So how much of the mark at the end you're getting. So this one, I believe, is the section that you get the most marks. So it might be worth checking it, but it depends on how many drugs are you checking actually. Fine. So that's the answer for the first one. Um, and that's the answer for the second one. So let's just go through it how I would have done it. So you read the question well. Basically, you look at which drug is causing what. So for this question type, prescription review, there's two ways they can ask you questions. So basically, which drug is causing this condition that they're asking for? So which drug is causing the melena, either directly or indirectly? Secondly, they can ask you about any kind of dosing error, like in this one. So which prescription that's on there that has been wrongly prescribed. So that's two ways it can come up to you. So you read the question well, they tell you to find a drug which is directly and indirectly causing melena. Fine, you know what you're looking for. So you recognize the drugs that are directly linked. So from your memory, you know apixaban, well, causes bleed anyways. Blood thinning drug, it will cause a bleed. So that's the first one. And then for those who doesn't know, so there's an appendix. Basically, on the BNF, you type Appendix 1. It comes up with a list of whole lots of medications, with whole lots of conditions. So here it is. It it comes with that list of conditions and drugs, basically which under which you will find drugs that cause those effects. So if I type Appendix 1 and I look into the anticoagulation anticoagulant, anticoagulant effect drug or antiplatelet drug, it will give me drugs that increases my risk of bleeding. So when I did that, I found out that basically citalopram is the one that increases your risk of bleeding as well. So that's second one. And then the third one, use if you don't find all of your drugs, that's when you use your interaction checker to say if any interaction with any other drug potentiates its effect. So for this one, clarithromycin and apixaban has an interaction. So clarithromycin increases the exposure of apixaban. So I could see in the previous answer, like in the chat, that clarithromycin interacts with statin. For the first answer, it wouldn't be it because statin and clarithromycin doesn't increase your risk of bleeding. Its interaction while we're looking at causes of melena here. So fine. And then the second question was, yeah, has been wrongly prescribed. So in the prescription bit, what they're asking you is to look which one, when the doctor has prescribed, has been wrongly prescribed. So like, for example, here, I've written a list of medications basically that they can trick you. So methotrexate is usually prescribed weekly, so not daily. So same for, so if we look at diuretics, so you never prescribe it at night, you prescribe it, if it is once only, you give it in the morning or twice daily. It would be one around lunchtime or 2 p.m. Just because you don't want your patient to go, because diuretics make you pee a lot. You don't want them to wake up at night, pee, and then have a risk of falls because most of those patients are elderly anyways, so they are more at risk of falls. So that's the reasoning behind it. Also, aspirin 75 milligrams, you give it for secondary prevention. The 301 is for acute management of ACS. Atorvastatin 80 milligrams for secondary prevention. For cocodamol and paracetamol, just remember that the maximum would be 4 grams per day of paracetamol. And it kind of depends uh, on the weight as well. So if it is less than 50 kilograms, you would prescribe basically 500 milligram of paracetamol, so QDS. While if they are greater than 50, then it would be 1 gram QDS. So it kind of depends on their weight as well. So if a patient's on low molecular weight heparin, you check their GFR because it depends. So which dose you're prescribing depends on the kidney function. So levothyroxine and digoxin are prescribed in micrograms. So for this section, like they can just put in the levothyroxine for where they are prescribing is in milligrams instead of micrograms, just for you to be aware of. So here, the one that they have wrongly prescribed is simvastatin because usually it is prescribed at night. The reason being that statins are that cholesterol is basically the synthesis of cholesterol happens at night mostly. So simvastatin, which helps in preventing this in a way. So in dealing with this, help at night as well. If you take it at night, it would help in that process. Next question, if we go through this. Anyone see the question section? No, fine. So for the appendix one, I can show you guys where you can find it. If you're not able to, just type in the chat, I will show you. But it's very helpful because here, like you see, so some of those drugs you need to know because it kind of forms part of your medical training as well, like nephrotoxic drugs. You need to know like diuretics, ACE inhibitors, NSAIDs, JAN, spironolactone are all causes of AKI. So you have that at the back of the mind. So if you have a prescription review question about what could have caused a nephrotoxic effect or an AKI, you know those drugs. Same for other things like hyperkalemia. So if they give you spironolactone, you know that. So ACE inhibitors as well and trimethoprim, just remember those. So hypokalemia, salbutamol, prednisolone, diuretics, except potassium sparing one, obviously. So hyponatremia is a common one that comes up a lot. So diuretics, antidepressants are the common ones. Ototoxicity would be aminoglycosides, which are gentamicin, basically. Yeah. So this one, we're going to the planning management section. So 53-year-old admitted to hospital with 4-day history of abdominal pain and nausea. So poor food intake for the past few weeks, alcohol dependent. Drug history include folic acid, thiamine, and he usually drinks 7 to 8 pints of beer most days. He has not had any alcohol for the last 2 days because basically he has been having that nausea and poor food intake. So he appears disoriented, confused, jaundiced. And observation-wise, blood pressure a bit on the lower side. He has got 2 centimeter tender hepatomegaly on an abdominal exam. Otherwise, the investigations are unremarkable, but um, just select which one would you be giving him in terms of the appropriate management option. So you can type down your answers in terms of 1, 2, 3, 4, 5 instead of writing the whole thing. So the correct answer is Fabrinex. The main reason is that so we know he's got alcohol dependence. We know he has not consumed alcohol for the past 2 days. So this put him at risk of Wernicke's encephalopathy just because he has not been having his daily thiamine as well, which he should have been taking the long term, which is basically vitamin B supplements. But he has not been having that. Plus, he basically not have been consuming alcohol as well. So those two factors make him more at risk of getting Wernicke's encephalopathy. And this is more important to manage. So by giving Fabrinex than giving lorazepam at the moment, because lorazepam is given to help with agitation and as part of the alcohol withdrawal process. So you give lorazepam if the agitated, so alcohol withdrawal symptoms. So anything like trembling, shaking, so that's when you will be giving it, and also because he hasn't been drinking and he's a chronic alcohol user. But the most important thing to give him is the Fabrinex to prevent Wernicke's encephalopathy. And following this dose of Fabrinex, whether or not he can take orally, then you would be giving him uh, the thiamine again. So the what is yeah the thiamine again. So the correct answer is Fabrinex. Hope this makes sense. So even if you don't know he hasn't been taking the thiamine, so it doesn't kind of change the management plan because anyway you will be giving him the Fabrinex given that um, he he's in he hasn't been taking his alcohol for the past 2 days, and this puts him at risk of having Wernicke's encephalopathy because of his alcohol dependence for the past 2 days. Yeah, and I guess you can just because he had poor food intake, that's what I assume he couldn't be taking his thiamine as well. So next question. 63-year-old woman seen in medical assessment unit with swollen leg. Past medical history of hypertension, angina, drug history, ramipril, bisoprolol, nicorandril. Uh, so he's a lifelong smoker. I also, so his obs not really remarkable. Respiratory exam is unremarkable as well. So just his left leg is swollen, red and firm to the touch. No, there is no heat or tenderness. There's a 4 centimeter difference between the circumference on the left and right calf. So I'll do your ultrasound, demonstrate thrombosis within the popliteal vein. So what is the most appropriate management for him? Just choose, so put in the chat. which one you would like to give this patient? Yeah, the correct answer is four, like most of you have said. I think all of you have said four. So we know he's got a DVT. The treatment for a venous thromboembolism is an oral DOAC, so not an IV one. So it wouldn't be the IV infusion of agatroban. So that one out, so it's already out of the equation. And you know it is a DOAC, so it wouldn't be aspirin. So you're left with rivaroxaban, apixaban, that too, but there are different doses. So you just have to go onto the BNF. So basically, the right answer is the 10 milligram one, which we will be giving orally 12 hourly anyways. And afterwards, this is when, after you've loaded that patient, then you can give them the 5 milligram orally 12 hourly afterwards. So the 5 milligram one is after. So when you've already loaded them with the 10 milligrams. So acutely, you will be giving the 10 one. So the rivaroxaban, the if you want to give that one, the dose would be 15 milligrams, 12 hourly. So it's not that one anyways. So that's why it's a correct answer. So planning management, the things that basically they can test you on are common clinical presentations where there are evidence, like clear evidence-based guidelines for us to prescribe. So those are the conditions I found that have clear clinical guidelines, which you can basically look into the treatment summaries to see what you would prescribe. So many of them we have covered, like so ACS, alcohol withdrawal, we've kind of briefly touched on it. So ACS, heart failure, AF, BTE, hypertension, I mean, just the emergency we've touched, the asthma, COPD, anaphylaxis. Just have a look at stroke and epilepsy. Just so we've touched on to status epilepticus. That's one thing. Hypoglycemia we've seen, DK, we've talked about the fixed rate. Type 2 diabetes will come on to the different drugs that you can prescribe, and thyroid disease will go again onto hypothyroidism and levothyroxine later on. So gout and rheumatoid arthritis, just have a look at the treatment summaries. And those ones, which basically when patient comes in with overdose, so you can go into the poisoning section. So for opioids, you will be giving naloxone. For benzodiazepine, you will be giving flumazenil. But yeah, there are a lot of things in the poisoning section, including like if someone comes in taking an overdose of paracetamol, what you should do, when you should be given like acetylcysteine and all that. So just for you to be aware of. So next section is on drug counseling. So a 52-year-old man presents to GP for a medication review. He has recently been diagnosed with CKD. The decision is made to start atorvastatin 20 milligram orally once daily. So what is the most important information that should be provided to this patient? Yeah, that's correct. It's the third one. So common things that you need to know about statins is like statins taken at night, and usually you need to do a blood test before starting them on statin. So you will see all that when you go into the BNF, and then the monitoring section will tell you which blood test to do. The most common and the main side effect that should it's not most common, but it's the rare side effect, but it's the most, I guess, the worst thing that can happen to them is rhabdomyolysis, which basically means a breakdown of your muscle. So it's a rare side effect, but it is something that we should always counsel a patient that if they've got any muscle pain, weakness, or malaise, like it's written there, so to come back immediately to A&E because they might be having the breakdown of their muscles because of this drug. So also remember that statins interact with clarithromycin or grapefruit juice. So one thing to remember. And then, I mean, if we go through each one of them, it is so statin is a very rare cause of gynecomastia. The one that you should always remember is spironolactone and digoxin, which kind of commonly comes up. So those are the ones that commonly cause gynecomastia. Um, Atorvastatin should be taken at night, which is true, but it's not the most important information to be giving a patient when you have that rhabdomyolysis thing here. Uh, Peripheral neuropathy is not a common side effect, and atorvastatin may be given with or without food. That's true, but it's not the most important thing to tell your patient about. Next one, you're counseling 62-year-old patient with type 2 diabetes who are just being started on dapagliflozin, which is an SGLT2 inhibitor. So which of the following key points should you include in your counseling? So the correct answer is the second one. So let's go through each one of them. So the first one, it is incorrect because basically dapagliflozin alone wouldn't be causing you to have hypoglycemia. And also, if they do have hypoglycemia, you wouldn't tell them to stop the medication immediately as well, um, because it's rarely a cause of hypoglycemia because it's less likely it's the one that's the culprit in there. Um, Secondly, warn the patient about the risk of UTI, so urinary infection. That is true because the most common side effects that you always need to tell patients about is the risk of UTI. Just because SGLT2 inhibitors, they work by basically inhibiting the reabsorption of glucose. So more glucose are excreted in the urine, which promotes bacterial growth. So you're more at risk of getting UTI, of getting Fournier's gangrene, which is basically necrotizing fasciitis of the genitalia, um, just because it promotes bacterial growth in that area. And also to remember, it can cause euglycemic DKA, so diabetic ketoacidosis, but the glucose would be normal. That's why it's called euglycemic ketoacidosis. So one thing to always counsel a patient who's going to be started on SGLT2, apart from telling them, well, UTI, the gangrene thing, is that they can get the euglycemic ketoacidosis, which is they should come back, they get nausea, vomiting, abdo pain, they are short of breath, as they can be acidotic. Um, so the third one would be reassure the patient that mild dehydration is expected. Well, it is expected because it has a diuretic effect on the patient, but it does require action. So if you're dehydrated, you would need to drink water. It does not, yeah, that bit is incorrect. So tell the patient that this medication will replace all other. No, it's used in combination with other drug. It's not used on its own. Advise the patient to avoid taking his medication with food. Well, it can be taken with food or without food. Its relation to food is irrelevant in the question. So that's why it's the second one. Next, well, drug counseling. There's a lot going on here, which I wouldn't be going through, but you can have a look in your own time. But to remember, metformin put you at risk of lactic acidosis. That's also why you need to counsel them on if they feel sick, unusually tired, short of breath, come back to A&E. SGLT2, we've gone through. The benefit of it is weight loss that they get with the SGLT2, also used in heart failure. So sulfonylurea, this is the one that causes hypoglycemia a lot. So that's why a lot of their monitoring instruction would be, and also the things that you would tell your patient would be about hypoglycemia. So also you need to avoid them in pregnancy and breastfeeding, again, because of the risk of neonatal infant hypoglycemia. So that's the red flag one for hypoglycemia. So thiazolidinedione is the one basically you need to remember when there's a patient with bladder cancer, because most of the questions would be, well, for a patient with type 2 diabetes, they can come in and they ask you to prescribe a drug, but their past medical history includes, say, UTI and bladder cancer, and they ask you to prescribe a drug for this patient. Then you know the contraindication would be SGLT2 because of UTI, and because of the bladder cancer would be thiazolidinedione. Just remember that. Steroids depends whether you're taking it, you're inhaling it, like if you have asthma, so it will inhale corticosteroids. But so if you are taking an inhaler one, so the most common thing would be you can get an oral thrush. That's why we tell patients to rinse their mouth after taking the inhaled corticosteroids. If it is an oral one, take it by mouth. So there are a lot of side effects which I've listed here. Next, GTN spray, we've gone through it. So isozolbide mononitrate is the one basically you use in treatment of angina, but remember you need to do asymmetric dosing for it, which basically means that for other drugs, what you usually do is you give them twice daily, so every 12 hourly. But for this one, you can't give it like at regular intervals just to prevent tolerance, because if you give them every 12 hourly, they will become less responsive to that drug. So what you usually do, you can give them at 8 a.m. and the other one will be at 2 p.m. And then again, the next day will be 8 a.m. just to prevent that similar cycle of it being given 12 hourly every time, so a regular one. So that's the thing you need to remember. And then carbimazole can cause agranulocytosis, where you're more at risk of infection. Next, levothyroxine. Well, it's taken on an empty stomach. Should avoid eating for 30 minutes afterwards. And remember that with iron or calcium carbonate, the absorption of levothyroxine is reduced, so you keep them at least 4 hours apart. So we will cover other drug counseling drugs like on hypertension, antibiotics later on in other sessions. Um, well, Next one is the adverse drug reaction one. So a 61-year-old man presents to GP for results of their routine monitoring blood tests. He's asymptomatic, past medical history, hypertension, type 2 diabetes, AF, which is paroxysmal. Anyways, drug history, ramipril, metformin, sitagliptin, amiodarone, and rivaroxaban. So select the prescription that's most likely to be contributing to the elevated liver enzymes. So if you look there, what's elevated is the ALT, NAST. Those are the ones. So which one do you think causes elevated liver enzymes? Yes, so for the isozolbide mononitrate is the main thing to remember is the asymmetric dosing. So for your regular medication, say you're taking bisoprolol, so 2 times per day, say you take it 8 a.m. and then 8 p.m. and you repeat that every day. You can do that for all other medication just because you don't develop tolerance when you use that regimen. So tolerance means that your body builds it's so the response to that drug is not the same, so it decreases if you take it at the same time. So for this one, it happens. So that's why you need, it's called asymmetric dosing, where basically you don't need to take it every time at regular intervals. So usually the two daily doses should not be spaced evenly, so not 12 hourly instead. So they are given unevenly to allow a nitrate-free period each day as the patient develops tolerance to the drug, so it becomes less effective. So you give it, say, 8 a.m. and 2 p.m. on that day, and then you repeat it again the next day, 8 a.m. and 2 p.m. So for that section, so the answer is amiodarone. So the way that I knew this was the answer is that I went to Appendix 1, like I told you before, and I went to that section for hepatotoxic drug, I think it's called. Um, so things, the drugs causing hepatotoxicity. And then I just found like, so if you go on there on Appendix 1, you can do Control F and then you search amiodarone in that, and then it will come up. You will see it highlighted in the hepatotoxic section, so you would know this is the one, while the others wouldn't be causing it. Hope this makes sense. Next one, 63-year-old woman presents to the GP with dyspepsia. Past medical history, anxiety, hypertension, drug history is citalopram, amlodipine. His gastroscopy shows gastritis, and his gastric biopsy confirms H. pylori. So select the prescription that is most likely to cause hyponatremia. So so the answer is omeprazole, and I mentioned it before as well. So common drugs to know about hyponatremia is your omeprazole and antipsychotic drugs like SSRI. Again, if you didn't know, you could just go again to Appendix 1, go to the hyponatremia section, or just do Control F and type omeprazole to find out where it shows. And then you'll see it is omeprazole and not the other ones it wouldn't show there. Fine. So all the drugs with adverse drug reaction is methotrexate. So I've written a lot there, especially like so how you take it weekly, and folic acid should be given weekly, but taken more than 24 hours after the methotrexate. These are all the things that they can ask you for the other section about drug management or drug counseling. And it interacts with trimethoprim or tremoxazole. And again, for statins, we've already talked about it. So yeah, so you use Appendix 1 for drugs causing hepatotoxicity, nephrotoxicity, and hyponatremia. So yeah, next one. So I think we've got 5 more slides to go before we finish. Uh, so 70-year-old man is referred to the emergency department with palpitations, past medical history of hypertension, AF, hypercholesterolemia. So ramipril as part of the drug history, bisoprolol, apixaban, torvastatin. So in terms of the examination findings, just as expected, heart sounds will be irregularly. So irregular, you will have that in terms of the pulse, and then bilateral ankle edema. Um, so for this patient, a course of digoxin, 125 micrograms, is prescribed. So select the most appropriate option to monitor for beneficial effects of this prescription over 7 days of treatment. So which one would you actually monitor to see whether the digoxin has been beneficial to this patient? So the correct answer is heart rate. So it just to know. So like I said before, there's two ways to treat AF. You've got your rate control and your rhythm control. Digoxin addresses the rate control bit of AF alongside beta blockers and calcium channel blockers. So the reason why it is heart rate because it is asking you the beneficial to monitor for beneficial effects. So how would you know? Because usually, even on the ward, the main symptom that the patient will tell you is that the heart is racing. So the way that you would know that it has acted beneficially for that patient is through their heart rate. So the heart rate is the most important option here for beneficial effects. So if we go for the other one, I know many of you guys have said digoxin levels. So we don't actually check digoxin levels routinely. So unless we suspect it is they have digoxin toxicity, that's when we check digoxin levels. So it's not done to check whether or not they are in the range or they are in the therapeutic range. So when we start someone, if we suspect they have toxicity, that's when we do it. So it's not routinely required to check it for routine guide treatment to guide the treatment. Um, Other things, I guess if you go into the monitoring sections, they would tell you basically before you start, you have to check serum potassium levels, which basically makes sense because hypokalemia can precipitate digoxin toxicity. But in that context, it's not the one to choose if you're looking for the beneficial effects, I mean, after 7 days. Um, Also, you can say palpitations, but the thing is that even patients who have good control AF can have palpitations. So it doesn't mean that basically you can just ask the patient about the symptom and then if they don't have it, then it's fine. It's mostly about the heart rate, which can basically on an ECG will give you whether it has increased or decreased or it is managed. That's how you would know. So next question. 29-year-old is admitted with persistent palpitations and lightheadedness. ECG shows AF with atrial flutter and responsive to rate control. After review by cardiology, a decision is made to initiate IV amiodarone for rhythm control. So select the most appropriate investigations which should be checked before starting treatment to reduce the risk of adverse effects of IV amiodarone therapy. So just a hint for this one, go to the BNF and find and go to the monitoring section. Yeah, for AF, I've put in the previous slide that you can find in the under the arrhythmia section for the treatment summary. Yeah, so for the digoxin, basically it doesn't tell you anywhere. So for that exam, it doesn't mean that all the answer would be in the BNF. Because they would put a monitoring section there. It's to monitor the drug, but this question specifically asked about, so how would you know that this drug has been effective for that patient? It's just to know what they are asking for. So the correct answer is the first one. You need all of them. This is kind of testing that you have read the whole of the monitoring bits. Because you go into the monitoring section, so it tells you need to monitor LFTs, serum potassium, which is your UNEs, and a chest X-ray before treatment. If you look in adults, so this patient is an adult, you need to do thyroid function tests. And then if you scroll down, you would see the IV use, for which you need to do ECG monitoring. So it will be all of them before you start treatment. So it's one of them. Basically, you need to read through things. sadly. Um, Anyways, so next one, 53-year-old woman attends GP complaining of worsening tiredness, lethargy, and mild weight gain. She also reports feeling unusually cold and constipated, past medical history of hypothyroidism, hypertension, depression, is on levothyroxine, 100 micrograms orally once daily, and other drugs. Anyways, the investigations are there. So select the most appropriate decision option with regard to levothyroxine prescription based on these data. So what would you do with the levothyroxine? Would you increase it, decrease it, leave it the same? So this question is about management of hypothyroidism. So like I said previously, the therapeutic goal is normalization of the TSH level, but also we need to make sure the patient is not symptomatic as well. So this patient is symptomatic. Plus, also the investigation shows that the TSH is still high, while you're trying to make the TSH back into the normal range. So basically, the answer is the fourth one. You need to remember for levothyroxine, like even when you start someone, you always increment it by 25 micrograms every time. So this patient has been on 100 micrograms. So you would increase it by 25. So if this one didn't work, so the next band would just be you increase it again by 25. And then after 4 weeks, you recheck the TSH levels. Um, yeah. So just remember for levothyroxine, you always increment by 25 micrograms. Fine. So let's see. 72-year-old man presents to the ED after coughing up a small amount of blood. Past medical history includes hypertension, CKD, and metallic aortic valve replacement, for which he is on warfarin 5 milligrams daily, and also ramipril for the hypertension and furosemide 40 milligrams daily. So on examination, those are the findings and investigations. So the investigation shows the INR is out of range. So select the most appropriate decision option with regard to the warfarin prescription based on these data. So I've put a hint down there. So warfarin, you can find it on the oral anticoagulant section in the treatment summary. So if you go on there, you find the warfarin, just have a look what we should do for this patient. So the correct answer is 4. Most of you said it. So just because, so that's the section that I wanted you to have a look at. So this patient basically is having minor bleeding just because he's just having one so episode of coughing up a small amount of blood. So it's minor bleeding, but it's not like major bleeding. So we know it will fall into this section because his INR as well is 5.3 and minor bleeding. So it tells you what to do. Stop warfarin, give vitamin K, and restart it when the INR is less than 5. So stop warfarin, give vitamin K. It should be slow IV. I think that one says oral PO, so that's why it's not the answer. It's by slow IV injection. And this is the end. Hopefully, you guys learned something today. Uh, do you have any questions at all? You can put them in the chat or, well,
Excuse me.
yeah.
Yeah, just got a quick question about when you prescribed about it was one of the diabetic patients who was on an ACE inhibitor and that was about which drug was incorrectly prescribed,
Yeah.
and it was a diabetic patient on a calcium channel blocker. And the question I had for you was, why was he? Surely wouldn't the calcium channel blocker be incorrect? Because if he has hypertension and diabetes, your first course of antihypertensive would be an ACE inhibitor, right?
So for which question you're talking about? Sorry. So was it the one
The
where
atorvastatin question, the one where about atorvastatin and being incorrect, and it was the one with the two columns.
oh, the one with the okay, yeah, I know which one you're talking
Yeah.
about. Let's have a look. Is it the one where there was the Melina one and which one has been wrongly
Yes,
prescribed?
that one. Yes,
Is it
that
that
one.
one?
Yeah.
Yes. So did you mention because the past medical history includes type 2 diabetes and
Yes, it mentioned type
yeah,
2 diabetes. So I'm just wondering why is it that surely wouldn't the incorrect prescription be surely the incorrect prescription should be the lacandapine, or are
because
they
he's
just
type 2
looking at
diabetes
yeah,
because
yeah,
calcium channel blocker.
yeah.
The age is 68 years old. Um, let me see. Should it not be so? This is a calcium channel blocker, right? So if they are greater than, is it not 55 years old, but they have type 2 diabetes, then you should give a calcium channel blocker.
Yeah, so that's why I'm
Yeah,
confused because surely you'd want it to be renal. So the question is, so hypertension from type 2 diabetes, you immediately go for calcium channel blocker, you sort of ignore the age. That's the guidance that I've got in front of me. ACE inhibitor, even.
fine. So it can be right as well, I believe. Let me just double check. Uh,
I'm telling you.
no. Yeah, that's right as well, to be honest, because the guideline says hypertension with type 2 diabetes should start with an ACE, and they didn't give us an exact reason why they didn't prescribe an ACE in the question. Um,
So just to clarify with this type of question,
yes.
um, not only do you have to check for the dose and the frequency and the route, you also need to check if it's even the correct drug.
Um, so usually it will tell you which one has been wrongly prescribed. So I don't
Oh,
think
okay.
they will
Yes,
ask you about the drug in itself, whether it is the right indication for that drug. It is mostly the way that it has been prescribed, whether the right dose, route, or frequency.
So on these,
So
on these
if they
questions,
want you, if they want you to pick up the drug that basically has been wrongly, I wouldn't say prescribed, but usually they tell you like this, like it's mostly about the dose, route, and frequency that they put something in it. Because there's a reason. Sorry?
Sorry, continue, sorry.
Because there's a reason why they put in that drug in the first place. And they will ask you what they want from you. But say for the other medications, they just ask you about interactions. I don't think that they will ask you to basically know the guidelines, because that's not what this section is about, the prescribing one practice.
Oh, this section, the main aim is to check your understanding of dose, route, and frequency, not the specific drug. If they wanted to pick up on that, they would give you that's for a different type of question.
Yeah, they will give you different types. So in the other sections.
Thank you so much.
Hi, sorry, I have one question. It's really quick. Will we ever be asked to prescribe specific units of insulin? Because in the BNF, it kind of said like as per patient requirements.
Yeah.
So how would we know how many units of insulin to prescribe, / would we need to do that?
So the kind of question would just be when someone has DKA, this is the one question that I've seen where you will be asked to prescribe a fixed rate insulin, and you know the dose should be 0.1. So per kilogram, I believe I've written it down for DKA anyways. So 0.1 unit per kilogram per hour. That's how you would know the unit for a fixed rate. But for the other ones, if they want you to prescribe something, they would tell you what they are usually on, and you have to pick what you would like to prescribe for them. So they will give you a specific unit they want you to prescribe, because like you said, it depends, it's patient dependent. So they wouldn't expect you to just give a random number. So they would give you the number, but you need to prescribe it for them. So they would check things like the route is right, or you're giving it before meals, things like that. Because they, like I said, it's not, it's patient dependent. Any other questions?
It doesn't matter if you're using 10 or 20% dextrose when prescribing glucose in the exam, right?
Well, it doesn't matter because you can just change the amount that you're prescribing.
So that's just not going to be a marking point.
No, that wouldn't be. But just you can prescribe either of them, but not the 50% one.
Yeah, perfect. Thank you so much.
If that's the last of the question, guys, can I just signpost you all to the feedback form? Rafiq and all of the other doctors have put a lot of time into making these sessions, and it's just really great if you can all give some feedback, and it also helps for like specialty applications and portfolios that this has become a national teaching program that these guys have designed across 4 months. So the more feedback you can give, the better. And thank you all so much for coming. A lot of you have asked about slides, and I'm still figuring it out. There should be a recording that uploads to this chat when I end this meeting, and then you can all watch it back with Rafiq's teaching. And then I'll try and figure out how to do slides in a similar way, and then it should mean everyone who attended gets them automatically. But thank you so much for attending. And Rafiq, massive thank you. That was a brilliant session. Freaked me out a bit and made me realise how much I need to revise, but that's the whole point. So thank you very much. Anybody, any problems, you can email us on manchestermeded@gmail.com or follow our Instagram and send us a DM, and we'll try and get back to you, and we can always pass any questions on to Rafiq that way as well.
Thank you, guys.
Thank you, guys. Yeah, I'm going to try and figure out how I stop recording.